Welcome to the deep dive. Today, we're plunging into a really critical topic.
Yeah.
How hospitals prepare for emergencies.
Right. These are the places we all count on when things, go sideways.
Exactly. So how do they brace for everything? Natural disasters, chemical releases, even things like cyber attacks or mass casualty incidents.
It's a huge range. And for this deep dive, we've pulled together some, pretty fascinating sources. U.S. government documents, guidelines from healthcare groups, academic research, too.
Yeah, good mix.
Our mission, really, is to cut through all the jargon and the complexity. We want to pull out the essential bits, give you a clear picture of how these places build resilience and, respond when a crisis hits, hopefully provide some of those aha moments.
Right. So for you listening, especially if you're keen on understanding how these intricate systems handle the unexpected, and you value maybe efficiency and thoroughness,
then this should be really insightful.
you'll get a real feel for the strategies involved in keeping our healthcare system strong when it's under pressure. Okay, let's unpack this. First up, the whole landscape of emergency preparedness. It's always evolving, isn't it?
Absolutely. It's not static at all. There's been a significant push lately towards better coordination between different programs.
Like which ones?
Well, think about the federally funded hospital preparedness program and the public health emergency preparedness programs. They're designed to work much more closely now.
Okay, that makes sense. They're both on the front lines.
Exactly. Hospitals and public health, they have to be in sync during a major crisis.
And it sounds like the actual requirements for hospitals are getting tougher.
Yes, definitely. The Centers for Medicare and Medicaid Services, CMS, they've really raised the bar. They've increased the emergency preparedness requirements, so hospitals face stricter criteria now to prove they can keep essential services running during and after, a disaster.
I also saw mentions of healthcare coalitions in the sources. What's the idea behind those?
Healthcare coalitions. They're really crucial for building resilience across the entire health system, not just one hospital.
So it's like a network.
Precisely. They bring together all sorts of partners, hospitals, EMS, public health, nursing homes, you name it, at all levels.
Okay.
Imagine, say, a big power outage hits a region. A good coalition would already have plans worked out.
Like for moving patients.
Exactly. Transferring critical patients, sharing resources. They have agreements in place before the crisis hits. That kind of coordination, driven by the coalition, is key to regional resilience.
That collaborative approach.
Yeah.
It just seems logical, doesn't it? A united front when resources are stretched thin.
Definitely.
The sources also really highlighted the difficulty of preparing for a medical surge, when patient numbers just explode.
Oh, medical surge is incredibly complex. It's way more than just finding extra beds somewhere.
Right.
You need the right staff with the right skills. You need enough supplies, medications, linens, everything. And you need the flexibility to maybe convert existing spaces or even set up temporary sites outside the hospital.
In the community, perhaps.
Yeah, potentially for less critical patients. It's about managing a sudden, overwhelming flood of people with all sorts of needs.
And then there's the really daunting idea of hospital evacuation.
Yeah.
That sounds like an absolute nightmare scenario.
It is. Evacuation is truly a measure of last resort, and the challenges are just monumental.
The planning alone must be intense.
Incredibly intricate. Think about the patient's different conditions, maybe complex equipment they rely on, transporting them safely, ensuring continuity of care at the receiving end.
And doing that during a crisis.
It multiplies the difficulty immensely. Huge inherent risks.
Right. So the big picture seems to be more connection, stricter rules, and a real focus on resilience across the board.
That's a good summary.
Okay, let's zoom in a bit. Preparing for specific threats, chemical agent releases.
Yeah.
The CCP program came up a lot.
Yes, CSPP, the Chemical Stockpile Emergency Preparedness Program. It has a fascinating backstory, actually.
Oh, yeah.
It came about because Congress mandated the destruction of the U.S. chemical weapons stockpile. But many of these storage sites, which were originally remote,
Communities grew up around them.
exactly, places in Alabama, Arkansas, several other states. So Congress realized these nearby communities needed dedicated support in case of an accidental release during the destruction process.
And this involved actual funding, not just a policy paper.
Oh, absolutely. CSAP is funded cooperatively by the Department of Defense, the Army, specifically, and FEMA.
Okay.
This money supports everything from building the destruction facilities to ensuring community readiness until the very last weapon is certified destroyed. There are still active sites, in Colorado and Kentucky.
So what does that funding actually do on the ground? How does it help prepare?
A huge part of it is exercises, really robust exercises, full-scale exercises every year. These CSAP communities, hospitals, fire, police, local government, they all participate. They simulate an off-site chemical release.
And test everything.
Pretty much. Alert systems, evacuation plans, decontamination setups, medical care delivery, the whole response chain.
Wow. And within the hospital itself, during these drills, what are they looking at specifically?
They're scrutinizing critical things like how efficient and accurate triage is, how well they set up and run patient decontamination. Is the incident command system working smoothly? How are they managing patient flow? And
coordinating with EMS coming in.
Yes, that coordination piece is vital.
I imagine personal protective equipment, PPE, is absolutely critical here.
Paramount. CSAP helps fund PPE for community workers involved in potential deacon efforts, usually OSHA level C for them.
But higher levels for others.
Right. On the military base itself, or for first responders going into a hot zone, they need higher levels. And crucially, the Army and OSHA require extensive ongoing training before anyone can use this gear real world or exercise.
The sources mentioned exercise response outcomes, EROs. What are those?
EROs are basically measurable goals. They track a community's progress on specific preparedness tasks over the whole life of the CSAP program in their area.
Can you give an example?
Sure. ERO 7 measures how fast and effectively they can get emergency information out to the public about a potential release.
Okay, keeping people informed.
And ERO 8 looks at the process for deciding when it's safe to return home, what cleanup is needed. That sort of thing.
So these EROs aren't just like abstract scores. How does tracking ERO 7, say, actually help?
Well, think about it. If there's a release, the faster people get accurate info alerts, news, social media, the faster they can shelter in place or evacuate safely.
Right.
If a community scores low on ERO 7 in an exercise, they know they need to fix their notification systems, find the bottlenecks. It directly improves public safety in a real event.
It sounds very data-driven. Any common challenges they keep seeing in these evaluations?
One really persistent one is personnel turnover.
People leaving jobs.
Yeah. Experienced staff leave, and they take that institutional knowledge with them. Where stuff is stored, who to call, the little procedural details. That loss of memory can be a real risk.
So how do they maintain standards with people coming and going?
They rely heavily on established benchmarks. Hospital performance is measured against Joint Commission emergency preparedness standards.
Okay.
And the whole exercise structure follows the National Incident Management System, NIMS, that provides a common framework. After every exercise, everyone gets a detailed report, strengths, weaknesses, recommendations. It drives improvement.
Okay, let's shift gears to another major threat category, mass casualty incidents, or MCIs. What are the basic planning assumptions hospitals use for these?
Well, the core idea is that specific MCI plans need to be fully baked into the hospital's main emergency operations plan.
So it's not a separate thing?
It shouldn't be. The assumption is you build on your base plan, the one you practice regularly, and then you scale it up rapidly for the MCI, managing a surge of casualties with all kinds of needs.
And triage seems absolutely fundamental here.
Oh, completely. Triage, sorting casualties quickly, prioritizing care based on severity and likelihood of survival with the resources you have. It's the cornerstone.
Comes from military medicine, right?
Its roots are definitely there, yeah. But now, civilian EMS and ERs use standardized methods, and the evidence is clear. Good triage saves lives in MCIs by getting the most critical patients treated first.
I've heard of START triage. How does that work, basically?
START is simple triage and rapid treatment. There's a pediatric version too, Jumpstart.
Okay.
They use a simple color code. Red means immediate, life-threatening, needs help now. Yellow means serious, but treatment can wait a bit. Green is minor injuries, the walking wounded, and black is for those unlikely to survive given the situation or who are already deceased.
Helps responders quickly sort large numbers of people.
Exactly. Tags or ribbons show the priority at a glance.
What kinds of events can actually cause an MCI? It seems like a broad category.
It really is. Could be biological, like a pandemic flu, or even a deliberate release, like anthrax. Chemical incidents, industrial accidents, or worse. Conventional things like explosions, big train crashes, building collapses.
Even food poisoning?
a large-scale foodborne outbreak. Yes, like botulism. And then, thankfully, rarer nuclear or radiological events.
The sources mentioned this dual-wave phenomenon for casualty arrivals. That's interesting.
Yeah, it describes a pretty common pattern after a sudden event. The first wave hits fast, maybe 15, 30 minutes.
Who's in that wave?
Usually people with less severe injuries, the ones who can get themselves to the hospital, to the hospital, the walking wounded again. Then the second wave comes later. This wave has more of the critically injured people, the ones needing EMS transport, maybe extrication from the scene.
Because it takes time for EMS to get there, treat, and transport.
Exactly. So the ER has to be ready for those two different surges, the initial rush of less critical folks, then the later arrival of the really severe cases needing ambulances.
That definitely impacts staffing and resource needs right at the start. What about families showing up worried?
Planning for family staging areas is absolutely crucial. You need designated spaces for them to get information and support.
Away from the chaos.
Ideally, yes. Sometimes hospitals coordinate with specialized groups like FEMRs in Florida, even if there aren't fatalities, because they know how to manage family assistance. For really big MCIs, emergency management might set up a joint family assistance center off-site.
Makes sense. Decontamination is another big piece, especially with chemical or radiological stuff.
Essential. You have to protect patients, staff, and the hospital itself from contamination spreading.
So designated areas, handling contaminated clothes.
Right. Clear protocols for segregation, managing waste, staging deacon resources, and importantly, a plan to care for the deacon team themselves. It's physically and emotionally draining work.
When hospitals plan for MCIs, do they have rough estimates for how severe the injuries might be?
They often use general planning figures, maybe anticipate around 20% red-tagged emergent cases.
Okay, the most critical?
Around 30% yellow-tagged, urgent but not immediately life-threatening, and maybe 50% green-tagged minor injuries.
But these are just guides, right?
Absolutely, just planning assumptions. The reality of any specific incident could be very different depending on what happened.
And how do they translate those percentages into actual plans for space, staff, supplies?
They usually have detailed tables or sections in their EOPs. They link those estimated acuity levels to projected needs, how much treatment space, how many staff in different roles.
Including maybe staff extenders.
Yeah, like LPNs or EMTs working under supervision. And of course, lists of essential supplies, meds, equipment for each triage category.
We hear the term surge capacity a lot. What kind of increase are hospitals usually aiming for?
Well, traditionally, the goal was often around being able to handle maybe 20% more patients than their licensed bed capacity.
But it's not just about empty beds.
No, that's a critical point the sources make. Real surge capacity depends just as much on having enough trained staff, adequate treatment space, and the necessary supplies to actually care for those extra patients.
Right. An empty bed is useless without a nurse.
Exactly. And if the surge is huge, they might need plans for alternate care sites, ACSs.
Like setting up in a gym or school.
Potentially, yeah. To handle lower acuity patients and keep hospital beds free for the most critical cases.
Okay. I was a bit surprised to read that the need for blood transfusions might sometimes be overestimated in MCIs. Why is that?
It often comes down to better pre-hospital care now. Things like tourniquets, hemostatic dressings, applied effectively at the scene by first responders.
But they control bleeding better before the patient arrives.
Exactly. That can reduce the immediate demand for blood products right when the patient hits the door. So hospitals really need tight communication with their blood bank and lab to manage inventory efficiently.
Sadly, fatalities are part of MCIs. How do hospitals prepare for that grim reality?
They have to have comprehensive mass fatality management plans, worked out beforehand with the local medical examiner and emergency management.
What does that involve?
Things like setting up temporary morgue space needs to be kept cool, around 38-40 degrees Fahrenheit. Having dedicated black MCI carts ready with supplies for handling deceased individuals respectfully.
And the psychological toll on everyone. Survivors, responders, staff. It must be immense.
Absolutely immense. Addressing behavioral health needs is now seen as a critical part of the response. It's not just for survivors and bystanders, but very much for the first responders and hospital staff, too.
The term fearful and distressed was used.
Yes, it's a broader term than the old worried well. It acknowledges the wide range of psychological impacts. Hospitals need plans for immediate stress support, psychological first aid, and access to ongoing mental health services for everyone affected.
Now, let's pivot slightly to a more modern threat. Cyber attacks. Is sobering how vulnerable healthcare has become.
It really is a huge and growing worry. Modern medicine relies so heavily on tech, EHRs, diagnostics, networks.
Makes them a target.
A big target. The National Cybersecurity Strategy from early 2023 really highlights this as a top priority now.
And the consequences are severe, financially and otherwise.
Oh, yeah. Financially, the average attack costs a hospital something like $11 million. Nationally, it's billions. Plus, the loss of incredibly sensitive patient data, millions of records compromised just recently.
But it goes beyond money and data, right?
Yeah.
It can actually stop them from providing care.
Precisely. A successful attack can cripple their whole IT infrastructure, lock them out of patient records, mess up communication, disable vital medical equipment, sometimes for weeks or months.
That's terrifying. Imagine needing critical care and the systems are down.
It has potentially dangerous consequences for patient care, absolutely. The sheer number of breaches reported in 2022 impacting maybe 52 million patient files just shows the scale of this.
So what's being done? How do they fight back?
It has to be a multi-layered approach. Collaboration between hospitals and government agencies is key.
And within the hospital.
They absolutely need robust, regularly maintained backup systems, hardware backups they can switch to quickly, and comprehensive cybersecurity incident response plans. What do you do when ransomware hits or data is breached? They need to test these plans rigorously.
Are there resources to help them?
Yes. Agencies like CISA, the Cybersecurity and Infrastructure Security Agency, offer guidance and tools for hospitals to mitigate risks. Things like multi-factor authentication, staff training on phishing scams, network segmentation.
What's network segmentation?
It's like dividing the hospital's computer network into zones. So if one part gets breached, hopefully the attack doesn't spread easily to other critical areas.
Okay, good practical steps.
Yeah.
Now, shifting from external attacks to internal challenges.
Sure.
Let's talk infectious disease outbreaks within hospitals. Healthcare epidemiologists seem central here.
They are absolutely vital. HEs are the specialists in infection prevention and control within the hospital's emergency structure.
They have specific expertise.
Highly specialized training in identifying, investigating, responding to, and containing outbreaks in healthcare settings.
And how do they fit into the hospital's overall emergency command structure during an outbreak?
They typically work within the Hospital Incident Command System, HICS. And HICS is designed to align perfectly with national systems like NIMS and the National Response Framework.
So everyone's speaking the same language, basically.
Exactly. It ensures a standardized, coordinated approach from the federal level right down to the hospital floor. It helps create that common operating picture so everyone understands the situation.
So the HE advises the incident commander.
Precisely. They provide that critical subject matter expertise on the disease, how it spreads, the best control measures. They're also heavily involved in developing and maintaining the hospital's emergency operations plan sections related to infectious diseases.
What goes into a good infectious disease outbreak protocol for a hospital?
It needs to cover a lot of ground. Specific guidance for different pathogens, clear communication plans, internal and external with public health.
Information tracking.
Robust information management, yes. Lab testing procedures, guidelines for vaccines or antivirals if available, waste management, isolation room availability, and critically, regular drills and exercises to test the plan and staff readiness.
Communication keeps coming up as vital.
Foundational. The HE helps the incident commander and the public information officer craft clear, accurate messages for staff, patients, families, the community.
Do they work with ethics committees too?
Often, yes. Especially if the outbreak forces changes in care practices or difficult resource decisions.
How do they spot outbreaks early?
Through effective surveillance. HEs help implement syndromic surveillance systems, often working with public health, to look for unusual patterns of symptoms. They also ensure the hospital is ready for medical screenings and has the right infection control measures like PPE and isolation capacity.
Are there specific patient groups needing special attention during outbreaks?
Yes, definitely. Pregnant women, immunocompromised people, they might have atypical symptoms or be at higher risk for severe illness.
And kids.
Pediatric patients need tailored approaches involving parents, recognizing they often need more hands-on care.
And this coordination has to extend beyond the hospital walls, right?
Absolutely. The HE is the key link to local and state public health departments, especially if an outbreak involves community settings like schools or nursing homes.
They participate in drills that involve multiple departments?
Yes, simulations often involve the ER, lab, security, ICU, environmental services. It helps test the whole system and ensure coordination with other facilities too, like specialized treatment centers if needed.
Okay, let's move into the really complex area of ethical considerations in disasters and mass casualty care. It seems the usual rules sometimes have to bend.
That's a really important and difficult point. Normally, patient autonomy, their right to decide, is paramount.
But in an MCI?
In a mass casualty or disaster, the principles of beneficence doing good and just as fair allocation of scarce resources often have to take precedence. The goal shifts to doing the most good for the greatest number of people.
Is that shift well understood by all providers?
Not always. The sources suggest that even with lots of preparedness efforts, not everyone might be fully aware of how these ethical priorities shift under extreme pressure.
And the sources argue that preparing beforehand is actually an ethical duty.
Yes, the argument is compelling. By investing in disaster prep planning, training, drills, healthcare teams ethically reduce potential harm and disruption when a crisis hits. It's seen as a professional obligation to be as ready as possible.
COVID-19 really threw these ethical dilemmas into sharp focus, didn't it?
Oh, absolutely. Staffing shortages, supply issues, overwhelming patient loads. It forced providers into incredibly tough decisions about who gets what resources, leading to a lot of moral distress.
What's moral distress?
It's the feeling providers get when they know the ethically right thing to do but are constrained from doing it or feel forced to do something they believe is wrong. The pandemic really highlighted the need for clear ethical frameworks for disasters.
One specific ethical challenge seems to be allocating scarce resources like blood or deciding on aggressive treatments.
Right. In MCIs, ethical guidelines often say limited resources, like blood, should go to those with the best chance of survival with that resource.
Which
tragically might mean that patients assessed as expectant or moribund, very unlikely to survive even with treatment, may not receive those scarce resources in extreme situations.
That must be incredibly difficult.
Unimaginably difficult. Similarly, highly resource-intensive procedures like resuscitative thoracotomy, opening the chest in the ER, are generally discouraged in MCIs to save resources for more patients. There might be rare exceptions, but even then, blood use would be strictly limited.
The idea of futility seems relevant here, too.
Yes. Assessing medical futility, whether treatment offers any meaningful benefit, often has to happen faster in a disaster. And the threshold might be different because you have to prioritize resources for those most likely to benefit.
These ethical issues also pop up in the ICU, especially for patients there long-term after a disaster.
Definitely. The ICU sees many who sadly don't make it, but also many survivors who face long recoveries and potential chronic issues.
So palliative care is important.
Crucial. And not just for end of life. It's about aligning patient and family goals with the clinical reality, providing support throughout a serious illness. Documenting goals of care for ICU patients early on is really important.
And communication with families in the ICU must be so vital, but so hard.
Absolutely essential. Clear, regular, empathetic communication. Scheduling meetings, listening, acknowledging emotions, avoiding jargon, offering realistic hope. It's all part of ethical care in that high-stress environment.
The sources also talked about the moral distress providers feel themselves. What causes that?
It can stem from many things. Feeling forced to act against your beliefs, making agonizing resource decisions where there's no good outcome, feeling you did something wrong or failed to do something right, even feeling betrayed by the system if resources or support seem inadequate.
It's critical to support the responders too, then.
Absolutely vital. Early access to counseling and support is key. Agencies like SAMHSA offer resources, coping strategies, mindfulness, dealing with compassion fatigue, guidance on returning to work after traumatic events.
Okay, our final big area. Building overall hospital safety and resilience. We looked at some guidelines from India that offered a good case study.
Yes, the National Disaster Management Guidelines for Hospital Safety in India. They take a very comprehensive, multi-hazard, interdisciplinary approach.
They emphasize learning from past needs.
Strongly. They mention things like the Gujarat earthquake, the AMRI hospital fire tragedies that really showed how vulnerable hospitals can be to different kinds of disasters structurally and operationally.
And it's not always about the building collapsing, is it?
No, often it's functional collapse. Essential services labs, ORs, utilities, records become unusable. That can take a hospital out of commission just as effectively as structural damage.
They also made the point that building in resilience from the start isn't necessarily that expensive.
That's a key takeaway. Integrating disaster mitigation into new hospital design often costs less than 4% of the total investment, a relatively small upfront cost for huge potential benefits in safety and continuity.
Raising awareness seems like a big part of their strategy, too.
Huge. Educating hospital staff and the community on things like first aid, fire safety, evacuation plans, safe construction. It builds a culture of safety.
And every hospital needs a specific committee and plan.
Yes, a Hospital Disaster Management Committee, HDMC, responsible for developing and implementing a Hospital Disaster Management Plan, HDMP, and a Hospital Incident Response System, HIRS. That structure is fundamental.
How do they ensure essential services like power and water keep running?
Through multiple strategies: adequate stockpiles, robust backup utilities like generators and water reserves, well-practiced evacuation plans, and strong networks with other hospitals for mutual aid. Detailed protocols for managing utilities are essential.
They also revisited triage protocols.
Yes, emphasizing sickest seen first, rapid evaluation, contingency triage sites, clear identification, and smooth patient flow management once the disaster plan is activated.
And surge capacity, again, needing more than just beds.
Right. It requires planning for manpower surges, recalling staff, using volunteers, adequate supplies, morgue capacity management, and efficient discharge transfer processes to free up beds.
The guidelines got quite technical about structural safety, especially for earthquakes.
They did. They set performance criteria. Critical units like ICUs need to aim for immediate occupancy after a quake, meaning they stay functional. Other areas need at least life safety so people can evacuate safely even if there's damage.
So higher engineering standards for critical areas.
Exactly. Using qualified engineers, adhering to building codes, especially for those critical parts of the hospital. They also addressed issues with irregularly shaped buildings, which can be trickier seismically.
And what about things inside the building during an earthquake? Equipment, ceilings?
Non-structural elements, or NSCs, they're critical too. Things can fall, break, block exits, disrupt care.
So they need specific protection.
Yes. Understanding if they're sensitive to shaking, acceleration, or bending deformation. Strategies range from common sense securing of equipment to engineered bracing for things like ductwork or pipework, ensuring connections can handle movement.
Quality control during construction and maintenance is stressed too.
Absolutely. Using certified artisans, licensed engineers, peer reviews of safety designs, and ongoing hazard-conscious maintenance checking structural elements, equipment, safety systems regularly, performing vulnerability assessments, and retrofitting older facilities.
Licensing and accreditation seem to be key enforcement tools.
Yes, they ensure hospitals follow relevant laws and safety regulations. The guidelines suggest strengthening these processes, updating building codes specifically for hospital functionality post-disaster, and embedding safety into public health standards.
Fire safety also got detailed attention.
Extremely detailed. Open space for fire trucks, fire separation walls, proper staircases, internal and external, horizontal exits, protected shafts for utilities, centralized fire pumps with backups, hydrants, rising mains, all crucial elements.
So overall, it's a combination of structural design, non-structural safety, operational planning, maintenance, and regulatory oversight.
That sums it up well. Plus, a huge emphasis on awareness, capacity building through training for everyone involved, administrators, staff, engineers, architects, and developing detailed, hospital-specific preparedness plans that are regularly drilled and exercised.
Those drills and exercises, they test specific skills too.
Yes, drills might focus just on notification procedures or resource requests, while larger exercises test the whole plan. They even provide frameworks for matching staffing to specific MCI types.
Our sources also touch on communication systems, again, even pagers.
Yeah, it's interesting. Pagers are still seen as surprisingly reliable for emergency notifications, especially if cell service or power goes down. A good backup.
And standard operating procedures, SOPs, for emergency codes like Code Blue.
Absolutely fundamental. Clear, well-rehearsed SOPs for Code Blue, medical emergency, Code Red, fire, Code Yellow, external disaster, etc., are crucial for a fast, coordinated response.
What makes a good Code Blue SOP, for instance?
It needs clear activation steps, defined team roles, leader, airway, circulation, recorder, a step-by-step protocol following standard guidelines like ACLS, and clear documentation requirements, plus a process for debriefing afterwards.
The debriefing step seems vital for improvement.
Essential. Reviewing what went well, what didn't after any emergency response helps refine the SOPs and improve performance next time. It's about continuous learning.
Lastly, there were some practical tips for improving communication between ER doctors and nurses. That seems critical in such a busy place.
Extremely critical for safe, efficient care. The recommendations included things like providers sharing their assessment and plan early on.
Letting the nurse know what they're thinking.
Exactly. Sharing pending tasks, clarifying orders clearly, not assuming the other person understands, nurses notifying docs promptly of changes.
Not just relying on electronic orders.
Right. Verbal communication is still key for urgent things. Using secure messaging for less urgent stuff. Adapting communication to experience levels and the ER layout. And crucially, valuing everyone's experience regardless of hierarchy.
That makes sense. The WHO checklist mentioned continuous reevaluation during recovery, too.
Yes, constantly reassessing patients, adjusting plans, arranging timely discharges, and keeping families and the public informed after the main crisis passes.
Wow. Well, this has been incredibly comprehensive. It's really quite staggering to see just how much goes into hospital emergency preparedness.
It is the planning, the training, the infrastructure, the ethical thinking, the constant focus on communication. It's a massive undertaking.
Today's deep dive really underscored that complexity, I think. How hospitals need robust plans, trained staff, resilient buildings, ethical grounding, and great communication to handle this huge range of threats.
And that integration of national guidelines, standard procedures, and constant evaluation is just paramount for them to keep functioning when we need them most.
It really makes you think, though, considering all these threats and how dynamic it all is. How can we, as community members, better understand and maybe even support what our local hospitals are doing to prepare? How do we build that collective resilience?
That's a really good question to ponder, fostering that community connection and support.
Yeah, definitely something to think about. Thanks for joining us for this deep dive.